Hi, my name's Hannah Peterson, and I'm co-presenting today with Ian Kahn. We are both from CDPHE, and today we'll be talking about exploring public health and clinical partnership to collect cardiac rehabilitation data in Colorado. We have 3 learning objectives. Today we'll discuss the importance of collaboration between public health and cardiac rehab programs to increase utilization and prevent subsequent cardiac events. We'll describe how partnership between public health and cardiac rehab programs yields valuable data, and we'll explain the necessity of a composite approach to data utilization.
The funding for this work comes from a CDC Innovations grant, and because it's innovative work, we're starting small in 9-county area, which includes the Metro Denver counties, Chaffee, and El Paso counties. It's also the start of a new strategy within federal funding as of October 2018, and cardiac rehab is a new area of work for CDPHE as well. So there's no historical knowledge within the department, and it is also why much of the work up to this point has been exploratory. It wasn't until approximately August of 2019 that the connection between cardiac rehab facilities and efforts on this work really began. And now we're starting year 3 of our 5-year funding cycle. So cardiac rehab is regarded as an effective form of secondary prevention, but it remains underutilized. In Colorado, recent Medicare data from 2016 showed that only 41% of eligible patients enrolled in cardiac rehab programs, and just 11% completed the program. We've learned that there is no single data source for all metrics of cardiac rehab data, including referrals, and we had to find other ways and sources to collect this data. And you can't change what you don't measure. So we are currently focused on determining baseline referral rates in collaboration with cardiac rehab facilities. And starting here, we'll lay the foundation for our future work on systems change to meet the Million Hearts goal for 70% participation in cardiac rehabilitation. This timeline of our methods outlines 2 processes that were happening in parallel. The top walks through the partnership building and development of Cardiac Rehab Advisory Group, or the CRAG, and the bottom represents the data collection process. We'll start at the top with August 2019, the purple line. And because this is new work for the state, we needed to identify the experts in the field who could help guide us. So in August, I began conducting discovery interviews with 9 cardiac rehab facilities found through the publicly available American Association of Cardiovascular and Pulmonary Rehabilitation, or AACVPR database. And I was able to get buy-in by simply asking if these folks would be interested in participating in the Cardiac Rehab Advisory Group. The CDPHE cardiac rehab team started planning for the CRAG, the first CRAG meeting, early in October. Surveys were sent out to interested members in advance to set the stage for the initial meeting. We wanted to identify challenges that they face with patient referrals so we could prioritize them, to get an idea of what they hope to get out of participating in the CRAG themselves, and to determine meeting logistics like when and how often to meet. The first CRAG meeting was held in December, where we got buy-in from members and have been able to maintain continued active engagement. And the CRAG really created a space for peer learning and helped CDPHE prioritize goals and brainstorm quality improvement initiatives. The group has continued to meet regularly with a systemic approach to determine what data to collect and how, identify barriers to referral and prioritize strategies. And after reconvening in May and making progress over the summer, Hannah and I made our specific ask to the facilities to determine the denominator for referral for all patients eligible for cardiac rehab. And now I'll turn it over to Hannah to talk about the methods we use for data collection.
So the green line on the bottom outlines our quest for data. In September, we started conducting a comprehensive search for available data. We looked into hospitalization data, both event data and into hospital record data through Coreo. We looked at insurance claims data through the all-payer claims database. We looked at registry data through AACVPR and through various survey data. So the problem is that there is no single place that had all of the data that tracked a patient from their qualifying event to their referral and enrollment. And there is a disconnect between the information collected at the hospital about the eligible population and the data collected by each cardiac rehab facility. So this meant that we needed to implement a system to capture actual referrals and use other data sources to validate that information. So in December, we started talking to individual clinics about using their AAC-VPR data. During the CRAG and one-on-one meetings, we discussed the type of information that was currently collected by each center, how various metrics were calculated, and administrative tasks such as how often the data gets uploaded and by whom. Throughout our discussions with clinics about various barriers, we realized that each clinic was unique, which could make reporting and aggregating data complicated. For example, we learned that some clinics don't have the capability to perform some qualifying procedures, so they send patients to other hospitals. This would result in an artificially inflated enrollment rate for one clinic and a deflated rate for another. We decided to pursue the idea of combining multiple data sources by submitting proposals to APCD and hospitalization event data to validate information and control for variance between clinics. Most recently, we've been working directly with the facilities to get basic EHR data. An ongoing challenge we've been facing is that the use of multiple data sources makes it challenging to track patients from one source to another, meaning it's difficult to know if an eligible patient actually enrolls in a cardiac rehab program. We're hoping to solve this by setting up individual EHR queries to capture specific referral rates for each facility so that they're able to track patients through eligibility, enrollment, and completion of cardiac rehab. We have three big takeaways from these initial phases. The first is the building of the CRAG. There is particular interest in improving the referral systems and implementing changes to patient tracking. We learned that many facilities have tried to implement tracking measures before and have encountered various barriers that the CRAG is working to overcome. Additionally, there is a willingness to improve. Some facilities have already implemented their own tracking systems and realized that their rates are lower than they originally thought. This reinforces the idea that you can't improve what you don't measure, and a huge success is their willingness to improve. The second result is that we have an increased understanding of the barriers to data collection and tracking. We know what we have, and we have concrete plans to collect what we need. And finally, we found that the collaborative partnership is necessary. Partnership with cardiac rehab programs is the only way that we can get some of the specific data that we need. And working with CDPHE is the leverage that many programs may need to make the systems changes.
The implications for this new public health work are many, but for us, these are the most immediate ones. Establishing new partnerships for collaboration in this work was critical. It is allowing us to capture data that would be otherwise unavailable to us from the cardiac rehab facilities. And the CRAG has provided a learning community for cardiac rehab professionals. It is a forum for CDPHE to learn about cardiac rehab at the systems level, and it was utilized for alternative purposes, such as navigating reopening during the pandemic. We've also been able to establish the CRAG, and these new partnerships have helped identify and prioritize areas for systems change to our quality improvement. With the engagement we have had thus far, we are optimistic that we'll get a sense of cardiac rehab referrals in the 9 counties in which we're funded to work. This data will help us understand where there are gaps and guide our approach for quality improvement. Finally, this work is in its infancy and is ongoing. We've got a lot of work left, and with the engagement from these new partners, we're optimistic it will lead to future success.
And finally, we wouldn't be where we are today without the help of our collaborators. This is by no means a comprehensive list, but we are greatly appreciative of each of them. Thank you for your interest. Our contact information is provided on the slide. But if you have questions, we will be at the poster session Wednesday, August 26th from 1:45 to 2:30. Thank you.